Ready to get started? It's noon. Awesome. Okay. Hello, everyone. Good afternoon. My name is Rima Buktha. I'm a PGY1 resident here at Erlanger, and today I will be presenting my CE entitled Pick Your Poison, an Anti-Venom Review. To begin with disclosures, I have nothing to disclose. This is just a list of some of the abbreviations that are going to be included throughout this presentation that I wanted to include for your reference. After this presentation, I would like everyone to be able to identify patients who would benefit from anti-venom administration, review the 6 criteria used in the Snakebite severity score, compare and contrast the 2 FDA-approved anti-venoms for Cratalid snake bites, and then review a snakebite protocol to evaluate if anti-venom is appropriate in the dosing regimens. To achieve those objectives, we will begin with some background on snake bites, followed by the clinical presentation, diagnosis, and patient assessment and treatment. And then we'll, at the end, discuss how all this will apply to Erlanger as a health system. So to begin with some background, there are about 30 species of venomous snakes in the US that can be divided into 2 families. The first one being the Severity family, which consists of a subfamily called the pit vipers, and those include things like rattlesnakes, copperheads, cottonmouths, or water moccasins. And the other one is the elapid family, which includes coral snakes. For the sake of this presentation, and due to our geographic region, we will focus on the pit vipers. So briefly, we will review how to identify venomous versus non-venomous snakes using a rattlesnake and a corn snake as an example. So looking at the head, venomous snakes have a triangular shaped head versus non-venomous usually have a more round-headed shape.
Smiled.
Looking at the head of these snakes, venomous snakes have an elliptical pupil and a heat-sensing pit, which is unique to the pit vipers. And then the non-venomous snakes have a round pupil and no heat-sensing pit. And of course, venomous snakes have fangs versus non-venomous snakes do not.
Survive that degree of isolation.
And then looking at the tails, venomous snakes have a single plate versus non-venomous snakes have a double row of plates.
He needed to join the conversation.
And then looking at our region specifically, including the Smokies, we can actually see all 3 different types of the pit vipers. But here at Erlanger, we primarily see copperhead and cottonmouth bites.
The red, white, and blue bow tie.
And usually snake bites can be categorized into 2 different types. So dry bites, which means that little to no venom is injected into the person. And these patients usually remain asymptomatic for 8 to 12 hours after the bite. And actually, it's reported that 10 to 25% of pit viper bites are actually dry and hence do not indicate anti-venom use. Comparatively, the other type is a wet bite, so that does mean that envenomation occurs. And so the technical definition of envenomation is an array of injurious effects and pathophysiologic changes that follow after release of venom into tissue at the site of a bite. And pit viper's venom is known to be hemotoxic, so it can attack the tissue and blood, and it can contain various proteins such as cytotoxins, neurotoxins, myotoxins, anti-clotting agents as well.
You're on first.
Unfortunately, the incidence of envenomation is unknown because reporting is not required, and actually most patients do not seek medical attention after a bite unless it's severe. And most of these do occur during the summer months when snakes are more active and people are more out and about.
Really a nice guy.
It's reported that about 5,000 people are treated for snake bites in the United States, and annually up to 5 deaths,
Feel nervous?
which have significantly reduced since the introduction of anti-venom.
Smiled. It really doesn't take that
So
much.
now we'll move on to the clinical presentation of snake bites, since it might not be seen frequently, but it is a medical emergency that requires prompt recognition and urgent management.
No, I'm sorry, I
So
scared him.
here we just have an illustration that kind of shows the fang marks or scratches that you would commonly see around a bite site. So this venomous snake has more of a puncture-like wound versus non-venomous snakes kind of look like they have scratches.
Stuff. Are you okay? With
And then the physiologic effects are actually quite variable and unpredictable after snake bites. It can range from asymptomatic to life-threatening in terms of coagulation and neurotoxicity. And the magnitude of the clinical effects of venom is related to the snake species, the amount of venom the patient was exposed to, the location of the bite, and ease with which venom reaches the general circulation. So most actually just penetrate the subcutaneous tissue, but if it does get into the muscle, it can actually cause a more rapid entry into the systemic circulation. And then the exact content and potency of venom cannot be predicted. It actually varies among the snake species, where the snake lives, the age, the diet, and even the time of year. In general, there's three main effects of envenomation. The first being local effects, so the swelling or pain. There can even be systemic effects like hypotension, diarrhea, angioedema, bleeding. Most likely not severe, but it can cause severe bleeding. And then the hematologic effects, so abnormalities in coagulation markers.
Not to worry. All right, you say so.
So in general, after a pit viper bite, within minutes, most patients experience localized swelling because that's your body's first line of defense to try to contain and neutralize that venom. And then within an hour, there's more localized pain, edema around the snakebite adjacent tissues. And then within the first few hours is when most people show signs of systemic envenomation. So things like shock, nausea, vomiting, diarrhea, or weakness.
Some of those issues seem to really bother you.
And then one of the important or more notable complications of envenomation is up to 33 to 50% of people who are treated with anti-venom develop something called late coagulopathy, which is when the patient actually has initial normalization or control of coagulation parameters, but after 10 to 10 days, those parameters become abnormal again. And why this occurs is unclear. Some of the proposed mechanisms include that the venom half-life is actually longer than the anti-venom half-life, that there's a slow release of stored venom from tissues into the circulation. There might be a delayed onset of some of the venom components, and even dissociation of venom anti-venom complexes or anti-venom immune responses can occur.
Smiling back, I said,
And so now that we've reviewed some background and the kind of the typical clinical presentation, we'll now move on to diagnosis briefly. So diagnosis is really based on clinical suspicion, on the clinical signs and symptoms that you see the patient present with, any complaints of did they see a snake or were concerned with snakes. So unfortunately, there's no validated method to assess if anti-venom is indicated for snake bites. It's traditionally been relied on clinicians using subjective data to kind of categorize their patients as having either signs and symptoms of minor, moderate, or severe envenomation. There is a newer scale that can help us with standardizing how we evaluate progression of envenomation called the Snakebite Severity Score.
You look surprised.
So this score is just one of the ones that the FDA trials have also included, and I wanted to dive into it a little bit more, especially because it's going to be used at Erlanger. So this has 6 different criteria to judge the severity of envenomation. So things like pulmonary symptoms, cardiovascular symptoms, local wound features, GI symptoms, coagulation markers, and central nervous system. So the total score ranges from 0 to 20, and then higher scores indicate higher, greater severity of the bite. And so I just wanted to include this illustration of one example of a sliding snakebite severity score flow sheet used by a different hospital that kind of shows how each of the 6 different criteria are broken down and what is correlated to what point value. And then this is just the second half. And then I did want to dive a little bit more into the coagulation markers because this might be more useful when verifying anti-venom or evaluating if it's appropriate real quickly when you are in the queue. So this actually has really specific clear cutoff points for the PTT, the platelets, and the fibrinogen levels that do have indications.
No, but another interview I don't need.
I also wanted to review 2 studies real quickly since this is going to be used here. So the first study is the one that validated the severity score for assessment using comparing it to 2 blinded physicians. And so they found that the physician's assessment actually correlated with the score at presentation and at the point at which the patient's condition was worst. And this score actually had a 97% sensitivity in detecting a 1-point change in the score to detect a worsening condition.
Tell you now if I do. Skip the phone call.
And then the second trial is the resource utilization after The snakebite severity score was implemented into a treatment algorithm at an academic level 1 trauma center. So this figure shows their algorithm that they implemented that used the snakebite severity score to dictate whether the patient would get another loading dose of anti-venom or need another, or if they could start maintenance dosing. So in their pre-post evaluation, they found that there was a significant reduction in use of anti-venom therapy without increase in other healthcare utilization. So things like hospital and ICU length of stay, blood product transfusions, need for surgical intervention or intubation were not different pre and post their treatment algorithm. And they also calculated about $13,200 of savings per patient. So that includes not only drug costs, but personnel costs like nurses and care.
4 armed guards on a first date. No pressure.
So now we have reached the first knowledge check. Which of the following is not included when utilizing the snakebite severity score? A, local wound changes. B, GI symptoms. C, snake species. D, coagulation parameters.
Friends with the owner. We were able to get a table near a door in case of
I think I heard it, C. So that's correct. Snake species is not utilized in this scoring system. And I just wanted to reiterate the main utility in this score is in identifying if patients are getting worse from their baseline to ultimately help guide redosing of anti-venom and if it is required. So this would not be used at baseline to get a clinician to start anti-venom. Initiation of anti-venom is purely clinical judgment.
Yes, and kind of no, I guess.
Now that I've given you some of that, we're going to try to tie everything together and discuss how a patient presents and is assessed and treated once a snake bite is suspected. So sometimes before patients even present to the hospital, they are evaluated by EMS or life force. And so some of the key things that they're going to try to do is immobilize that affected area without compression, removing any jewelry or constructive clothing near the bite location, and obtaining IV access. And then their main treatment goal here is to provide pain relief. So opioids are actually preferred since NSAIDs can increase your risk of bleeding and also lead to platelet dysfunction. And then ultimately also avoiding tight tourniquets, mouth or mechanical suction and ice. And then once the patient presents to the hospital or ED, some of the key things in your initial assessment include things like marking the leading edge of swelling or tenderness every 15 to 30 minutes, continuing the immobilization and supportive care like the pain control, and obtaining your baseline coagulation parameters, so things like CBC with platelets, fibrinogen, PT, and updating their tetanus. So this is similar to other animal bites. So if an adult patient hasn't had a tetanus shot within the last 5 years, it is appropriate to update their tetanus shot. And then consulting the local poison center if they are already not involved, especially if you're unable to gain initial control of the bite with 2 doses of anti-venom.
Herself, she added.
And then also monitoring for envenomation signs. So gathering information about the snake bite, when did it happen, the species, if you can. Usually the patient will not know. And then any first aid measures, because here at Erlanger, most of these patients are transferred here from other facilities or from life force. So it's important to know if they've already received anti-venom out in the field. And then just looking for the other signs and symptoms we've already discussed.
Those aren't supposed
So there are 4 primary indications for anti-venom, and those include the progression of edema or edema that is more than minimal, hematologic abnormalities, systemic signs like hypotension or systemic bleeding, and any degree of neurotoxicity. Even though neurotoxicity is rare after pit viper envenomation, it can occur in about 5% of cases. So as you can see here, dry bites are not an indication for anti-venom. So the goals for anti-venom therapy is ultimately to achieve initial control. So it's a general term that refers to subjective control usually of the venom clinical effects. So things like halting the progression of swelling, normalizing platelet counts, and resolving the systemic effects. So anti-venom does not reverse any serious pathophysiological processes like tissue necrosis, respiratory failure, or anaphylactic reactions. And those all would need to be handled like normal.
Ones who don't know me.
And then based on the information you gather from the patient, such as when they think they got bit, amongst other things, it's ideal to give anti-venom early. So usually within 4 hours is the recommendation in most of the consensus papers out there, because that's been shown to improve patient outcomes and decrease the risk of surgical intervention. However, other studies have reported giving anti-venom within 24 hours and still seeing those same improvement in patient outcomes. And extending it up to 24 hours also allows clinicians more time to observe and continue evaluating the patients to see if anti-venom is truly indicated.
In the middle of redneck heaven. So that's why.
And now that we've kind of talked about when anti-venom is indicated, the timing, we'll now dive into the actual 2 options that are available to us in the US. So that is Cratalid polyvalent immune Fab, or Crofab, and I'll refer to that now as Fab, versus Cratalid immune Fab 2 or Anti-Venoms. So Fab 2 is what I'll call it throughout this rest of this presentation. So both of these products are actually now indicated for the same snake species bites. Fab 2 was actually originally only indicated for rattlesnakes, but after the FDA did a post hoc analysis, they expanded that indication for all North American cratalids. So they both act very similarly. They're Fab fragments of IgG that binds and neutralizes venom toxins. And Fab comes from sheep serum, while Fab 2 comes from horse serum.
Damn sure.
So this picture illustration shows the structure of Fab and Fab 2 and kind of compares them. So one of the big structural differences between these 2 agents is that Fab 2 actually has 2 venom binding regions. And so that kind of different protein structure in the larger size is what's thought to slow the degradation of this fragment and prolong its clinical effect. So that's why the half-life is much longer than Fab. So Fab 2 actually has a half-life reported of 133 hours compared to Fab, which has a half-life of 12 to 23 hours. And then we'll talk about the dosing. So Fab initial dosing ranges from 4 to 6 vials and can even get up to 8 to 12 vials based on the clinician's assessment and if they are exhibiting severe symptoms. Whereas Fab 2 has a set standard 10 vial initial dose. Both of these products have a dosing recommendation to repeat every hour until the control is achieved. So manufacturers recommend repeating it until clinical control is achieved, but the guidelines actually state that few patients require more than 2 doses in clinical practice. And then Fab has maintenance dosing requirements of 2 vials every 6 hours for 3 doses, while Fab 2 does not have any maintenance dose requirements. And we'll talk a little bit more about that later, onto why. And then as needed dosing, so if signs and symptoms re-emerge in a patient, it is indicated to give another dose of either 2 vials for Fab or 4 vials for Fab 2. And then just moving on to some basics differences. So Fab has to be stored in the fridge and only lasts 4 hours after you make it, versus Fab 2 can be stored at room temperature and can be used up to 6 hours after reconstitution. And then among safety differences, so Fab actually does have a contraindication of hypersensitivity to papaya versus Fab 2 does not. However, these are relative contraindications since snake bites are medical emergencies. The benefit may outweigh the risk here. They both have similar adverse reactions reported of hypersensitivity reactions and serum sickness, though rare. And they do have some common adverse reactions like itching, nausea, back pain. And then monitoring-wise, they both have similar monitoring requirements. So getting coagulation parameters within 1 hour of giving the anti-venom, and then 2 to 3 days after the last anti-venom dose, and up to 5 to 7 days after the last anti-venom dose to monitor for any late coagulopathy that can occur. And then, of course, if there's any signs or symptoms of bleeding, it's a good reason to recheck any of these labs. Now that we've kind of briefly talked about that, we're going to now assess the clinical and safety differences and kind of understand more of where the dosing regimens came from. So first we'll talk about a trial called Subacute Coagulopathy in a randomized comparative trial of Fab and Fab2 Anti-Venoms by Boyer and colleagues that was published in 2013. So this trial looked at 12 patients with rattlesnake bites at 3 different Arizona hospitals and compared Fab versus Fab2. And an important note is both of these groups had maintenance dosing. So in terms of baseline characteristics, since we do have relatively small sample sizes, it's harder to assess if these groups are similar. But I did want to highlight that the time from bite to anti-venom was about 1 hour longer in the Fab2 group compared to the Fab group. And then another important baseline difference was in plasma venom level. One of the patients actually in Fab2 did not even have detectable venom level. So that's why the average is lower in that group compared to Fab. However, that was not statistically different. And at baseline, both groups had similar platelets and fibrinogen levels, so indicating that they had similar baseline coagulation abnormalities. So they found that the venom levels were undetectable during the initial control in both groups. So they have similar efficacy in controlling initial snakebite and venomation. However, the Fab group had 67% of patients have a recurrent detectable venom level compared to Fab2, which did not have any. And then even 2 of the 6 Fab patients experienced recurrent thrombocytopenia in the subacute follow-up period of 2 weeks, so that they concluded that Fab2 may prevent delayed or recurrent coagulation abnormalities due to a longer half-life of Fab2. So based on that protein structure difference that they had that we talked about. Next, we'll talk about the comparison of Fab2 versus Fab, anti-venom for pit viper envenomation, a prospective blinded multi-center randomized clinical trial published by Bush and colleagues in 2015. So this trial looked at 123 patients aged 2 to 80 who presented for emergency treatment of pit viper bites at various US institutions. So interesting to note, in this intervention, they looked at initial and maintenance dosing. So they compared Fab2 with Fab2 maintenance dosing, Fab2 with no maintenance dosing, so using a placebo, compared to Fab initial dosing and Fab maintenance dosing. So at baseline, these patients compared to the last trial actually had longer time to anti-venom. Generally, this patient population did not look that different from the previous trial in terms of coagulation abnormalities. There was maybe slightly higher platelet counts in this trial compared to Boyer's study, but the fibrinogen levels were similar. So their primary endpoint of this trial was late coagulopathy. So they found that there was significantly less late coagulopathy in both of the Fab2 groups compared to Fab, and there was no significant differences in the adverse events, and they had similar immune reactions. So they were able to conclude that perhaps maintenance dosing with Fab2 is not required for initial control and even to prevent late coagulopathy. So this is why the FDA recommends you don't have to do maintenance dosing with Fab2. And then since these agents have been approved, it is important to kind of see what other institutions' experiences have been with these 2 agents. So now we'll talk about the comparison of Fab2 and Fab anti-venoms and rattlesnake envenomation, first year's post-marketing experience with Fab2 in New Mexico. So this study looked at 37 patients with rattlesnake bites who received anti-venom, and they also compared Fab2 versus Fab. Unfortunately, they did not report out baseline platelet or fibrinogen levels, so I'm not able to compare this study to the previous 2 trials. They did comment that initial hematologic effects were similar, and they defined that as having abnormal platelet counts, low fibrinogen, or prolonged INR. So they were able to find that there was an insignificant difference in recurrent, persistent, and late new onset hematological abnormalities in Fab2 versus Fab. However, there was a trend because 0% of the patients in FAB2 had any recurrent hematologic abnormalities. And both groups had similar rates of type 3 hypersensitivity reactions at 21 days. So they were able to conclude that there was similar findings to previous clinical data, and that FAB2 may also not require maintenance dosing because they did not use that at their institution. And then lastly, we'll talk about the initial experience with FAB2 anti-venom compared with FAB anti-venom for rattlesnake envenomations, reported to a single poison center during 2019 by Wilson and colleagues. That was published in 2022. So they looked at 123 patients with rattlesnake bites who received anti-venom. And so their comparator groups were FAB versus FAB2 versus a combination of both. In their statistical analysis, they didn't include any comparisons with patients who received both products because of a low sample size. At baseline, similar to the previous studies, the platelets and fibrinogen were similar. And bite to anti-venom start here was about 3 hours for both groups, which is similar to the first trial we talked about. So they found that there was significantly less late coagulopathy in the FAB2 group compared to FAB, and that there were no differences in adverse events, and they were generally considered mild by the clinicians. So this also post-marketing kind of experience trial supports previous literature suggesting that FAB2 is associated with less late coagulopathy. And then just to kind of summarize what we just discussed, so based on the clinical trials and the post-marketing experience publications we've discussed, the studies populations had similar baseline platelets and fibrinogen in patients, so they all had similar coagulopathy abnormalities. And that the time to anti-venom was similar, with one study exception having a little bit more prolonged time to anti-venom. And then in one report, late coagulopathy was 30% in FAB versus 5 to 10% in FAB2. So this just suggests that FAB2 has less late coagulopathy. And then in regards to serum venom levels, initial treatment and FAB and FAB2 are very similar to each other in initial control. And then at maintenance and follow-up, FAB2 actually reduces the serum venom level significantly more than FAB. And then all this kind of ties back to their half-lives and their structures. So just as a reminder, FAB2 has quite a bit prolonged half-life compared to FAB. And then some of the limitations of these studies is that there wasn't any comparison of other efficacy parameters, such as initial control or physical function. So things that patients care about, like limb mobility. And there's also unknown long-term anti-venom safety differences, since the patient populations are only followed for a short amount of time after. And then I also wanted to include a little bit about other therapies that sometimes people consider in snake bites. So some of those include blood products. You should only consider giving blood products in clinically significant bleeding and only administering those with anti-venom, since blood products can be inactivated by circulating venom. And then prophylactic antibiotics are not recommended, and rabies vaccines are also not recommended in snake bites. So just to dive a little bit more into the prophylactic antibiotics, since this is a difference compared to other animal bites that we think about, there was actually a trial that looked at 114 patients that gave IV antibiotics and compared that to patients who received no antibiotics, and found that there was no statistical difference in infectious complications like abscess formation or skin soft tissue infections. And then rabies vaccine, snakes can't actually carry rabies since they are not mammals. So rabies post-exposure prophylaxis may be indicated for things like dogs, cats, raccoons, or rodents. And then we are now at our second knowledge check. So physician AB calls to ask for a recommendation on the maintenance dose of FAB2 now that she has controlled patient ZY's copperhead snakebite. What is your recommendation? A, 0 vials, B, 2 vials, C, 4 vials, D, 6 vials. Correct. It is A. Based on the second clinical trial that we talked about, the FDA does not recommend Fab2 to have maintenance dosing. Our third knowledge check, based on the clinical trials, what is the one key difference between the two FDA-approved anti-venoms? A, Fab has less reported adverse reactions. B, Fab2 has less reported adverse reactions. C, Fab had less late coagulopathy than Fab2. D, Fab2 had less late coagulopathy than Fab. Correct, it is D. So now that we've kind of talked about all the background and the treatment options, to kind of help summarize and tie this all back to earlier, we're going to discuss how this all applies via a formulary change in a proposed protocol that, spoiler, got approved yesterday at PNT. So it is important to look at if we actually, how much anti-venom we use here. So in June through September of 2018, there were 32 orders of anti-venom, so that being Fab product. And then March to September 2019, there were 9 orders. And then March to September 2020, there were 32 orders. So this isn't uncommon order that you'll see here at Erlanger. And actually most patients who do have snake bites and require anti-venom are transferred from outside facilities like we previously discussed. And then, so based on the formulary change, we are going to move from Fab to Fab2 at Erlanger. And then just to highlight some of the key differences we talked about, some of the advantages of Fab2 is that it's now approved for the same snake bites as Fab. There's less redosing involved based on the longer half-life. And based on the absence of maintenance dosing, there's less reports of late coagulopathy. And there's a potential cost saving of $2,000 compared to Fab for a full course. And some of the disadvantage with Fab2 is it's unclear what the possible side effects are based on the clinical trials. And then this, I just wanted to include for your reference. This is the proposed or approved order set for Avid. So the first part includes the patient assessment. So like we talked about, do we know what type of snake it was? What are the signs, symptoms of envenomation? Did we get our baseline labs that we needed, and completing the snakebite severity score? And then there's a second part with a directed snakebite assessment. And I really wanted to reiterate that if there are no signs of envenomation, it's most likely a dry bite and no anti-venom is indicated, and that you should just provide supportive care and observe these patients for up to 8 to 12 hours. And then this also just kind of is more extended of the previous slide. The second part of this order set will include the orders, so any labs that are pertinent based on the signs of envenomation, if they have mild or moderate. And then if they do fit into the moderate or severe envenomation category, then they'll get to order anti-venom using an order panel, which lays it out for them. The initial dose, reviewing the labs, administering it as soon as possible. And then if control is not achieved, repeating the dose by using the snakebite severity score. And then it goes into more late dosing or re-emerging symptom dosing. Then recommending to contact the poison control center if they're not involved already, and especially if they're unable to obtain control despite giving 2 doses of anti-venom. And then in summary, snake bites are considered a medical emergency, so it is important to promptly evaluate and treat these patients. Currently, there are 2 FDA-approved anti-venoms for Cratalid snake bites, so Fab and Fab2. The evidence suggests Fab2 has less late coagulopathies compared to Fab, which is actually a pretty common complication when using Fab. And both products have similar side effect profiles. And lastly, not all snake bites require anti-venom. And now, does anyone have any questions? Yes. Mm-hmm. So the advice I would give, so the snake bites, yes. So the question was, what advice would I give pharmacists who are verifying these orders, especially in terms of monitoring the coagulation markers? So in Epic, they're going to include that snakebite severity score. So that'll be a good way, quick way to see if it's been documented that someone's looked at it. So that's a good starting point to assess if someone's done it already. And then 2, moving on to the labs part. And so they should be able to see what values gets what points in that flow sheet. So just double crossing and checking. Mm-hmm.
So you can't always rely on those markers because some of them are delayed. So in terms of using those coagulation assays you mentioned that are good for pharmacists to look at, how should we utilize those results when they're available in the chart? When making recommendations about whether to give or
Mm-hmm. So the question was how to evaluate coagulation markers in terms of making recommendations, since snake bites are a clinical diagnosis. So that is a tricky question for sure. So I think one of the first things I would do personally is look at something I can concretely assess, so objective data like the coagulation parameters. And then if I saw documentation of any swelling or if they hit any of these other 5 criteria that were included in the snakebite severity score, I would try to find that in the chart. And if I couldn't and it looked inappropriate, I would reach out to the provider to make sure that we weren't inappropriately giving someone anti-venom, since it's not a benign drug for sure.
you have to wait on those to be elevated before you give it.
For the coagulation parameters. The question was, do you have to wait for the coagulation parameters to be elevated before giving it? So with snake bites, we're really looking for a decrease in those coagulation parameters. So one of the signs and symptoms that is predominantly found in snake bites is a reduction in those coagulopathy. However, that's not the only symptom that gets evaluated in the snakebite severity score. So if they hit really high marks and like they have CNS changes, they have GI issues, pulmonary symptoms with elevated heart rate or respiratory rate, then they could qualify without having any changes in coagulation parameters. Yeah. Yes.
Can you tell us what the difference in compounding is between the Crofab and the Anti-Venom?
The question was, what is the difference in compounding between Crofab and Anti-Venom? So when I was looking into this, I found that Crofab per vial requires at least 5 minutes to reconstitute, and then Anti-Venom takes a minute. So significantly less time to reconstitute Anti-Venom compared to Crofab. Yes.
When we get these patients, typically they'll have already received anti-venom and EV. A question I get a lot of times from providers is, how long do we have to keep them? How long do we have to monitor them after getting that therapy? What would you recommend?
The question was, how long would I recommend monitoring a patient in hospital? after giving anti-venom. So based on their clinical course, if they are improving, then they could do outpatient follow-up for their coagulation parameters. I would suggest at least keeping them until you get initial control, and then at least 2 or 3 days to make sure that you don't see any initial signs of late coagulopathy. Yes. The question was, since Anti-Venom is able to be stored at room temperature, would I expect an increase in its use? That's a good question. I think Life Force will be able to carry that product, so it may just be a reflex response to give Anti-Venom as more out in the field. So I do anticipate probably seeing a little bit of an uptick, but based on using that protocol, we'll be able to better assess if they actually need to redose them better, I think. Yes.
And they have limited room on their trucks.
Gotcha. Yes.
I was just wondering, from a logistical standpoint, how is that to actually compound it and deliver? Is it something that's diluted to IV pack, or how long is it administered over? I don't have any experience with it.
So the question is in regards to Anti-Venom and the compounding logistics. So from what I read, each vial requires 10 mils of like normal saline to be reconstituted. And then you can put it into an IV piggyback, and usually it's infused over an hour. Yeah. Are there any other questions? Yes. So here are my references, and this slide shows you how to claim your CE credits, and here is the code. All right, thank you guys for coming and listening to my presentation. I appreciate it. Have a good rest of your afternoon.